So we've built our muscle from the molecules up, from the cells to the myofilaments. We've put them together in different fiber types. We've looked at the fuel that's used, the metabolic machinery. Now we're going to start talking about actually doing work with our muscle organs as a whole. And so we know the job of a muscle is to contract. That's the muscle's job. It's going to contract, it's going to shorten. And what that muscle is attached to and how the muscle is arranged sort of in an architectural viewpoint depends upon what the work that's going to be done. And so we mentioned as we generate a contraction, as we accomplish work, we are going to recruit the smallest motor units first. Now, somebody just explain to me, very simply put, what is a motor unit? What's a motor unit when we talk about muscle? Well, we know it's going to be muscle cells. It's got to be muscle cells. But how do we define a motor unit relative to how many muscle cells? One motor neuron. How many muscle cells are innervated by one motor neuron? That defines the motor unit. Sorry? Depending on the muscle. Yeah, it could be a couple and it could be thousands. So, not only are we going to recruit the fewest motor units possible to accomplish the work, we're going to generate the minimum stimulation we need to get a contraction to occur. And that's a threshold. And we've talked about thresholds before, especially with action potentials. So with an action potential, to get our muscle started down that pathway of contraction, what is the membrane threshold to start an action potential? I've worded that in a little bit different way. What is the membrane potential threshold to start an action potential? Louder? Negative 55. That's also the threshold to open what? What channel? I heard somebody mumbling over here. Sodium voltage gated channel. So when we look at a muscle contraction, we're also talking about a threshold that's going to start moving that muscle to enable it to accomplish the work. And so we're going to add some terms in that are specific for the muscle organ, which is the whole thing. You had your practicals yesterday, right? And today? Okay, identify that muscle. Ooh, very nice. You're ready. I'll just tell them you all get A's and you don't have to worry about it, right? Will that work? I wish. So we're talking about the whole organ, much like the bicep. So a single twitch is one single contraction relaxation period that stems from a single stimulation, one signal from our motor neuron. And when we look at this contraction relaxation period, we're going to go through different stages. The first part is the latent period. This is the part where you start signaling and until you reach that threshold, that minus 55 millivolts. Latent means nothing's happening. But then as soon as we reach that threshold, minus 55 action potential, we release calcium from which organelle inside the muscle? Where's calcium stored? SR, sarcoplasmic reticulum. Calcium binds to troponin. Troponin pulls tropomyosin out of the way. Boom. We get our cross bridge, power stroke. ADP leaves. Y'all aren't making a sound. But you remember, right? That's all going to take place. And that's going to be the contraction period. The power strokes. Pulling on those filaments. Sliding them, shortening the sarcomeres. But since we only have one single stimulation, it's as if it's going to be on, then an off. And the off is going to be the period it takes for the muscle to relax completely. And so the relaxation period, that's resetting, reestablishing our cross bridges in a ready state. And again, what additional molecule do we need to reset our myosin heads? Another molecule of ATP. 2 ATP per latent contraction relaxation cycle. And so this just shows the tension of the muscle, relaxed on both ends, maximal tension right at the end of our contraction period as we're accomplishing the work. But especially when the muscle has been at rest and then all of a sudden you put it to work, the muscle never completely relaxes. There's always going to be a certain amount of tone, a certain amount of tension on that muscle. It's almost like, again, we've talked about the bow and arrow before. When you have the string on the bow, there's some tension there. The only way you're not going to have tension is if you take the string off. So consider your muscles loaded in the bow even when it's not pulled back. Now here's another example of our motor units. How many motor units do we have illustrated on the screen? I heard 1. 2. I see 2. Anybody else? Let's see, we've got 1, 2, 3. We've got maybe about 10 terminal boutons. Over here, maybe we have about 15 terminal boutons. How many motor units? 2. Because what defines a motor unit? Is it the number of fibers, the muscle fibers? No. What defines a motor unit? The motor nerve. The motor nerve, and we have 2 of them, the purple and the green. And so signals from our central nervous system are continually stimulating our motor nerves. And those go out to our muscle fibers to keep a certain amount of tone, even when you're sleeping. Now in 239, you'll get to the respiratory section. And in the respiratory section, you will probably hear about sleep apnea. Have you heard about this yet? Sleep apnea? And probably many of your dads, it's more prevalent in men than in women, but it's exemplified, and the chief symptom is snoring. How many of you have a dad that snores like a sawmill? Okay, does your dad snore, and then there's brief periods of quiet, and then a really loud snore, and he keeps, is that your dad? That's sleep apnea. Classic sleep apnea. Do you know what's happening during those quiet periods right before you get the real loud snore? He's not breathing. He's not ventilating air. Because when you sleep, your muscles decrease their tone, especially the muscles in your throat. And in your respiratory section in 239, you're going to see the way we inhale is we create a vacuum in our lungs and air is sucked in. And when that vacuum happens in your lungs, if your pharyngeal area, your laryngeal area, if it's too loose, if it's not enough tone, that vacuum just closes it and the air can't get through. And so your body goes into hypoxia, your blood oxygen goes down, your fight or flight nervous system kicks in and it wakes you up a little bit so that in that more wakeful state you can get increased tone, opens up the airways, and that loud explosive snore is not a snore, it's gasping for air. And then the snoring starts again. Now if your dad does that, you got to get him to the doctor. You have to get him to the doctor. Because untreated sleep apnea leads to hypertension. What's another name for hypertension? High blood pressure. Untreated high blood pressure can shorten your life expectancy in half. But it also increases the risk for that individual of a stroke. Reggie White. Anybody know the name Reggie White? Defensive end for the Philadelphia Eagles back in the day. I think he's the sack leader, or he was in the NFL. He died from untreated sleep apnea. So if there's ever a tough dude, that is one tough dude, but it got him. It's very easy to treat. It's very easy to diagnose, but it's very dangerous if it's left untreated. That's how this tone, this muscle tone, even when you're resting, is important. All right? So your brain's always working. Your muscles are always under a certain amount of tone. So when we look at muscle performance, we're going to recruit the smallest motor units possible. We're going to use the smallest stimulus possible. You can say our bodies are efficient, or you can say our bodies are lazy. Either way you want to look at it. We're not going to do more than we have to do. We're not going to burn more ATP than needed. And so when we look at stimulus intensity coming from our motor neurons, part of our motor units, we're going to see in our peripheral nerves. Now you understand this term nerve is a bundle of nerve cells. And we're going to talk more about that once we get to our nervous system chapter next week. But each one of these would represent the nerve going to a certain muscle fiber, so this represents the number of motor units. Remember how we talked about recruitment again? So when we look at our stimulus intensity, we're going to recruit more and more until we get the work done. And you see, as we recruit more and more, as we involve more muscle cells, we're going to increase the tension or the strength of that muscular contraction until we get to the point that we've maximally contracted. And if we do more and more and more and we're still not doing any more work, we can't shorten the muscle anymore, that's our limit. So we engage more motor units. The muscle contracts more and more and more until we've reached the top. And if you've ever lifted weights before, you know there is a maximal amount of weight you lift. And if you've ever added more and tried to lift that, you know you get to a point it's like, it's not going to go. Maximal contraction for that day. Because there's no more motor units, there's no more muscle fibers that you can recruit to get the work done. So as we look at that recruitment, as we look at increasing the stimulus, these are referred to as graded responses. When you put all that together, you start with the first grade, the second grade, the third grade. You see what we're doing? That's just a different name for that motor unit recruitment. Graded response. All right, so we can recruit more. We can also increase the stimulus from the nerve itself. Instead of just one stimulus, we can send stimuli really, really quickly. So when we talk about a twitch, in this case, we can say a twitch is less than 10 stimuli per second. And if we send those signals at that rate, what we're going to see is we're going to see our muscle contract, relax. Contract, relax. Contract, relax. So in this case, we see, what? How many twitches? We see 4. And you can physically see your muscle moving, relaxing, moving, relaxing. But we don't have to stop with just that few. So let's say here we increase it now. Our stimuli frequency, 10 to 20 per second. Now what we're going to see is that the muscle never really completely relaxes before we have the next and before we have the next and before we have the next. Because what's happening as we do them more rapidly, we don't have sufficient recovery time. We can't remove all of the calcium from the troponin. We can't get all the calcium back into the sarcoplasmic reticulum, so the muscle never completely relaxes. but it doesn't stay maximally contracted either. It's not rapid enough at 10 to 20 stimuli per second to hit that. So now let's increase it to 30 to 40. Now, has anyone ever had the, what's the therapy where they put the electrodes on you and they stimulate? Stim. You have ever had that? It gets to a point that you can feel it hitting you, but then when the pace increases, it just feels like a constant kind of vibration. That's what we're talking about. It's that same sort of thing, increasing that stimuli. Instead of using electricity, we're using our nerve signals, our action potentials. So at 30 to 40, not only do we not completely relax, but now we barely get finished with the contraction before the next one starts. And before the next one starts. Now do you see what we're doing? We're adding on top of each other. It's as if one stimulus is standing on the shoulders of the next, and on the next, and on the next. So what we have is referred to as summation of our stimuli. But since we never really arrive at that maximal state of contraction and stay there, which is called tetany, we refer to this state as incomplete tetany. You reach your maximal contraction, but you have these really short periods of a little bit of relaxation. And so this looks like your muscle is just quivering. Here at 10 to 20, we can actually see the contractions. Here, the muscle is just quivering. It's like a twitch. But if we go upwards of 50 per second, now do you see what's happening? Bam. You get complete contraction, no relaxation periods, and it just looks like the muscle is staying contracted and not moving at all, where in fact, it's moving so rapidly you don't see the relaxation periods. Those cross bridges are just working like pistons to hold that muscle in that contracted state. And what happens here, that's your muscle fatigue, that's muscle failure. And you're done. That muscle's not going to contract. So we can have more stimuli, we can recruit more motor units, and we can increase the frequency of our stimuli to make our muscles contract faster, contract stronger. So do you see we've got different muscle fibers, we've got different fuels. Muscles are extremely complex and extremely versatile. Because when you think about the wide variety of things you can accomplish and the work that you can do, your body's a pretty amazing machine. Now, the last thing here that's going to affect your ability to get work done, it's what we refer to as the muscle length. And I really want you to think more along the lines of a sarcomere than necessarily the whole muscle. But you do understand the length of the sarcomere relates to the whole length of the muscle. Because all your sarcomeres are going to be doing the same thing within each muscle fiber. And so when we look at our sarcomere at rest, we are at its maximal contraction capability. Because the overlap part of your thin actin and your thick myosin, you know that darkest part of the A band where they overlap? That is the perfect amount of overlap so that you can have the maximal contraction. So, and that's where we typically start. But if our fibers are already partially contracted, if we have so many stimuli hitting that muscle can't optimally rest, then that very next contraction is going to be weaker because we haven't engaged as many cross bridges from the beginning. And I think you can also envision that if our fiber is overly stretched, so, if it's not only at rest, but we hyper stretch that muscle. When you let your arms dangle, if we're talking about biceps again, right? Isn't this what y'all call it? The biceps? So when you let your arm dangle, that's sort of the perfect amount of rest and stretch. But if you hyperextend your elbow, you're stretching that even more. Now we're in this overly stretched period, And if you try to contract your muscle from that point, it's going to be a weaker contraction because you don't have the maximal overlap that we do at our normal resting length. That's why a lot of times when you see these gym folks and they're doing curls and they go all the way down with that curl bar, their biceps are hyperextended. And that's another reason why the hardest part of a curl is where? Getting it started. That's the hardest part, getting it started. So when you're doing those kinds of movements, be cognizant of the fact of the stretch of the muscle. In many instances, going all the way down and hyperextended is detrimental to what you're trying to do. When you do a curl it up. Don't go all the way to your chest because you're resting, right? Have you ever felt that? You get up here, you're like, okay, look around. See what I'm doing? Yeah. And then when you go down, don't go down and let it dangle. Just go down to the part you got that normal bend in your elbow and come back up. So you shorten that movement, you're going to maximize the work you're doing with the muscle, and you're going to maximize the stretch of the fibers. Same thing with triceps. You ever seen the guys that do the triceps? They come up here and they go all the way down. When you're coming up here, you're hyperstretching the triceps. Stop about right there and go down. That's all you have to do to get those triceps working because of the maximal overlap of your thin actin and your thick myosin. Does that make sense? It's as if when you overly stretch or you're overly contracted, you're playing tug of war and there's not as many people capable of pulling on the rope. You want all hands on deck, and that's that resting length of all of your sarcomeres. And so this is showing, this is when we're at rest, our nice overlap. Here where we're, this is our nice overlap. This is going to be contracted, and this is overly stretched. So this is going to be your maximal tension of contraction in this range. You're not going to get real good contraction here, and you're really not going to get it when it's overly stretched. And there's some stretching going on right there. You got to throw a cute kitten in at least once a semester, right? Or a puppy. All right, now with everything we can do with our fibers, with our motor units, with our tension and overlapping of our sarcomeres, there's really only two types of work you can do. And both of them are named ISO. And ISO means what? ISO means the same. And so our two types of work are either going to be isometric or isotonic. Remember, tonic refers to tone or tension. So we're going to think of that as strength. Same strength or same length, isometric. So on the left, where we see isotonic, this model is holding out a book and basically raising the book up. When you are doing work and your muscle is shortening, that means you have engaged enough motor units to accomplish the movement, to accomplish the work, to raise the book. Once you start raising the book, are you going to engage more motor units? No, that's all you need to do to raise the book. So the tension, the strength is going to stay the same, but as you raise the book, as you do the curl, what's happening to your bicep? It's shortening. So in this case, isotonic, the shortening of the muscle, accomplishing work. Now the opposite of that is on the right side. And here we got the book, we're holding the book out, the book is not moving. Now I saw the commercial for Sam Adams, Oktoberfest. Have you seen that commercial? Where the people have the stein and it's a contest to see who can hold the beer stein out here like this the longest. Have you ever, we used to get punished in, you people have no clue what school was like. Because y'all get like D-halls and in lunch suspensions. No, we got like cruel and unusual punishment, like having to stand in the back of the room and hold our arms out and put books on our hands You have to stand here. Anybody have to do that? Y'all are soft, man. Y'all are just soft. No, that was one of our punishments. Have you ever had to just hold your arms out with something in them for a period of time? It gets heavier and heavier and heavier, and you have to contract your muscle longer and longer and harder and harder. That is a type of isometric. Your muscle doesn't shorten because it's not moving, but you have to work harder and harder and harder to maintain that position. Now, almost any kind of work that you do is going to involve both. And again, let's talk about the curl. You're in the gym, you got a barbell with some weights on it. When you first start engaging your muscles, we're going to do the fewest motor units possible, right? Those first few motor units probably are not going to be sufficient to move the weight and shorten the muscle. So initially, when you're increasing the tension but your muscles aren't shortening, that's isometric. But then once you engage enough motor units, then your muscles start shortening, you start moving the bar. Now, the tension, the strength isn't going to change, but your muscle's shortening. That's isotonic. You see the difference between the two? Isometric, your muscle isn't shortening, which means you're not moving anything. Isotonic, your muscle is shortening, you're moving an object, but you're not having to add any more power. You're not using any more motor units. And those are the ways that we can classify the kind of work we're doing. I see a couple of glaze. This is kind of like hypertonic, hypotonic with our diffusion. You have to sit down and think about it, but really, when you find that point that the light bulb comes on, it's really simple. All right? Just remember isotonic, same strength, isometric, same length, as it refers to the contraction. Now, here's the dreaded E word, right? Exercise. Make it a part of your lifestyle right now. If you don't, when you get old like me, it's hard to do. But really, when you look at what exercise is doing, it can do two things. One principally, one only very slightly, but your muscle fibers are going to hypertrophy. Hyper means what? Above, more. And in this case, what's going to be more is your muscle cells are going to be filled with more myofibrils. You're going to have more thin actin and thick myosin. You're going to have more glycogen. You're going to increase your mitochondria because with more myofibrils, you've got to have more ATP, right? Glycogen's the fuel. Mitochondria, the powerhouse of the cell, producing your ATP. The other thing that's going to happen that we don't have listed on our slides is your muscle fibers are going to add more nuclei. And this whole idea of adding more nuclei is pretty cool because as your muscle cells hypertrophy and you get stronger, you add more nuclei. Now, when you stop working the muscle, and we're going to see this coming up in the next slide after this, but your muscle cells are going to get smaller. They're going to atrophy. You know, when you're not in season, maybe you're not working out and stuff, do you ever sense that your muscles are kind of, your ability to run it fast is going away? Recently, studies have shown that even though your muscles atrophy, the number of nuclei don't decrease as quickly as the myofilaments. And if you begin to start working out again with those increased nuclei, your muscles hypertrophy more rapidly. So that makes lazy people like me feel better. I was like, I'm resting, but I still got nuclei. Okay, I can come back. I can come back. Now, the other thing that can happen is hyperplasia. Hyperplasia means you add more muscle cells. Now, that's going to be very minimal at best. You have some cells associated with muscle called satellite cells, and some of those satellite cells can, under certain conditions, become more muscle cells, but typically this is not going to substantially enhance the size and the strength of your muscle. That increase in size and strength is coming from the hypertrophy. And so it makes sense. If you increase the size and the number, the size of the muscle, hypertrophy, or the number of muscle fibers, you're going to be able to generate more and greater muscle tension. You will be stronger. And that's really part of the reason of exercising, to become stronger, but to also lose weight. Shift your body fat for lean muscle mass. Now you realize weighing is one of the worst things in the world to ever do. Because as you're working out and adding muscle, muscle is heavier than fat. Check your measurements. You can tell if you are becoming more fit when your pants don't fit, right? I hate my pants. I hate my pants because they tend to be too tight more than they're too loose. And I go, man, shouldn't eat that piece of cake. Well, shouldn't eat both pieces of cake, right? That's usually how that works. So you use them, you build them up. You don't use your muscles, you lose them. And that loss of muscle mass, the loss of myofilaments, is called atrophy. And we're not talking about minimally. I mean, we're talking you lose considerable mass. Look at the difference in, okay, what's this muscle? Gastrocnemius. Look at the difference on both sides. Now, we've had a couple of ACL. Do we have a couple of ACL folks in here? A couple of them? I was shocked. This must have been about 23 years ago when I blew mine out. I was shocked after my surgery, which I blew my knee, 2 weeks of physical therapy to kind of strengthen it up a little bit, had my surgery. About a week after that, I go to PT. Well, I go in, and I had this little physical therapist. She was about that tall. I called her Little Hitler. She was so mean to me because I'm lazy, right? Y'all figured that out already? Oh, she would call me such horrible names to try to get me to do stuff. But it hurt. I don't like hurting. Pain I'm allergic to. But she said, okay, we're going to do some toe raises. And she put like 10 pounds on it. I'm like, please, don't insult me. 10 pounds? So she said, okay, so she jacked it down to maybe, I don't know, 75. I don't know what she had on there. She said, okay, do it with your good leg. I'm like, back up. I don't want to hurt you, that guy thing, And so I'm like going up and down, yawning, what's for lunch, And she said, okay, do it with your other leg. I'm like, look, it was my knee that I hurt, not my calf, please. Back up. It didn't move. I was like, did you lock it? What? In the 3 weeks since my injury, she got a tape measure. My gastrocnemius had decreased in diameter 1.5 inches. Was I still walking around? Yeah, I was still walking around. I was still doing all of my normal activities. But unbeknownst to me, I was favoring it. I was kind of limping, easing into it, and that was enough to lose 1.5 inches of diameter of my gastrocnemius. So, when you have your patients that are in bed, and they're in bed for a long time, you have to understand they're not going to be comfortable. They're not going to want to get up. But getting them up, getting them moving is going to help cardiovascular, and it's going to help muscle tone. But it's going to be one of the hardest jobs you're going to have to do, especially if I'm your patient. If I see you walk in, I'm just going to say, I am so sorry. You're going to earn your money today because I'm a bad, bad patient. Now, one of my least favorite topics, and again, if I'm your patient, you're going to have to deal with this too, us old people. But with age, your muscles change. Now, anytime you see the word penia, you're going to understand that penia means less than. Thrombocytopenia is a condition in which you have too few platelets. Erythropenia, you have too few red blood cells. And in this case, sarcopenia means that the number of your muscle cells decrease. You're losing muscle cells. Now, this is so not fair. You can't add cells, but you can lose cells just because you get old? That's not right. They're getting smaller. You have a harder time adding the thin actin and the thick myosin. You lose myoglobin. You don't have as many capillaries going to the muscle. What does that all mean? You're a weak old person. And when you look at a lot of what happens with age, and even when you look at what happens to a lot of athletes, especially the knees, the knee injuries. Did you see the knee injury? Who was the guy in the end zone that dislocated his knee? Who was that? What team was it? Yeah, did you see it? You can't watch that and not just get sick at your stomach. But the thing is, when you look at joint injuries, which are going to happen in the elderly, and you look at joint injuries that happen with elite athletes, the best way to stabilize the joints is to have your muscles in tip-top shape. Your muscles stabilize the joints, especially your knees. So if you're losing power and you're losing skeletal muscle, man, you're destined to have trouble with your joints. Not just with arthritis and those conditions, but just with instability. And when you injure your muscle, which you're going to do, you're not going to recover as well because, again, as we mentioned before, those satellite cells that can become new muscle cells, well, we don't have as many of those around. So as you lose the muscle fibers and you damage the existing ones, you're not going to replace them very well. And then as you lose the muscle fibers, as you lose the extra replacement satellite cells, you're going to go from a muscle that has a ton of muscle fibers. Now you're going to get down to where this looks like bacon. There's a lot of fibrous tissue. Fibrous connective tissue cannot contract. It's going to rob you of power. It's going to rob you of strength. So one area in which a lot of geriatric folks are really, really starting to not push necessarily. You always have to be cardiovascularly healthy. So again, you need to make a habit of doing that. But more and more, as we age, we need to do resistance training. Because we're going to lose these things. We need to make sure we have as many as we can possibly have. We need to make sure that they're as filled with myofilaments as they are, so we can optimize the cells we have left while we're losing others. Because again, we've got to stabilize the joints. And more you see that happening in geriatric facilities. But again, I can see me when I get to that point, I'm going to be like, look, I've lived this long, I'm not exercising anymore. I've done my time. Bring me some chocolate cake. Right? Okay. That was everything you ever wanted to know about skeletal muscle but didn't know you should ever ask, right? But skeletal muscle is just one of our three types. The other two types are going to be fairly straightforward. We're only going to talk about some slight differences in our muscle types. And the first we're going to talk about are our cardiac muscles. And of course, you find your skeletal muscles attached to what? The skeleton. Where do you find cardiac muscle? The heart. I mean, that's a no-brainer. It's easy. And as you look at cardiac muscle in a histological section, and you compare it to skeletal muscle, they look very similar. Did you see that in lab? Because they're both striated. They both have sarcomeres. They both have A bands and I bands. And there's only slight differences that we see. Now, one big difference. In cardiac muscle, they're involuntary. Whereas skeletal muscle, they're mostly voluntary muscles. Now, we do have some skeletal muscles that are involuntarily controlled, right? We've already talked about that. The diaphragm, the muscles of your eye that cause you to blink. Cardiac muscles, and as you get to circulation in 239, you're going to go through the action potentials and the driving forces of these pacemaker cells in your heart that cause your heart to beat without any nerve telling the heart to beat. There's an old story. It's got to be a myth. You know who Bruce Lee is? I mean, Bruce Lee's an old dude, but everybody has to know Bruce Lee. The story is Bruce Lee was so fast with his martial arts and so strong that he could reach into someone's chest and pull out their heart and let them see it beating before they dropped. And you thought Chuck Norris was bad. Now, whether that's true or not, if his hand was strong enough to go through your rib cage and your sternum and rip your heart out, if that part were true though, your heart would still be beating for a couple of seconds, a couple of minutes, because your heart doesn't need nerves to tell it to beat. We're going to see that the nervous system tells the heart to beat faster or beat slower. It doesn't tell it to beat. It does it on its own. Your skeletal muscle has to have the instructions from the nerves, or else it's not going to contract. Now, the other thing about our cardiac muscle cells, they're going to have fewer nuclei present. But the big thing is they're going to be branched. Skeletal muscle, straight cables. Cardiac muscles are going to be woven together. And they're going to create sheets and three-dimensional structures, because your heart is a hollow three-dimensional organ. And so as we put these characteristics together, and I have these characteristics listed on this slide too, so don't panic when I change here, because these are the same with a few more. I want to draw your attention to the last three. And really 3 and 4 are related. When you look at cardiac muscle, there's a ton of myoglobin. What does myoglobin bind to? Oxygen. 50% of the mass of a cardiac muscle fiber is mitochondria. What do mitochondria need to produce ATP? Oxygen. Are you getting the message? Cardiac muscle cells do not work without oxygen. If you deprive the heart of oxygen, instead of those heart muscles really going into fermentation, cardiac muscle cells are going to die. And that's called a myocardial infarct or a heart attack. So you've got to supply oxygen to those cardiac muscle cells. Now, the big distinguishing characteristic, other than the branching of the cells, are these junctions that join these individual cells together into this interwoven network. And these things are called intercalated discs. And when you see these in a histological preparation, you know right away that is cardiac muscle and not skeletal muscle. This is an electron microscopic picture. Here we have a light band with a dark line running right down the middle. What is the light band? The I band. And then we got the dark band. That's the A. Remember they alternate our sarcomeres? So here's I band, A band, I band, A band, I band, but all of a sudden instead of a thin little line, we've got this blown out, really jagged, lightning bolt looking thing. That is the intercalated disc. It's always going to hit where you would have a Z disc. And this intercalated disc is the junction between two of our cardiac muscle fibers. Now, do you remember the reedy apparatus in skin? The epidermal papillae and the dermal papillae? Well, it's sort of the same sort of thing with this intercalation. This is what it would really look like in 3 dimension if you could look at one cell. And the other cell is going to have its portion of the intercalated disc inserting into those, so that there's a lot of surface area to join these cells together. And part of the function of that intercalated disc is going to be to hold the cells together, but there's going to be a different functional role to these things as well. So when we look at that intercalated disc, much like a staircase, we have a part that comes up and a part that goes across, the rise and the run of those stairs. Well, when we look at the rise or the transverse portion of that intercalated disc, we have these junctional complexes called desmosomes. I think we talked about them earlier in the semester with epithelium. These are the Velcro that hold the cells together. That's for strength. But then in the flat portion, the lateral portion, we have gap junctions, these tunnels that allow the cytoplasm of one cell to be continuous with the cytoplasm of another. Because when we saw the action potential in a muscle, that sodium voltage gated channel opened. Sodium came in. And when sodium came into the cell, where did sodium go? Everywhere. And so with cardiac muscle, as soon as we have that change of ions and sodium comes flooding into the cell, if this happens close to a gap junction, that sodium is going to go through the tunnel that's the gap junction and into the neighboring cell. And that sodium is going to be able to cause an increase in the membrane potential in that neighboring cell to minus 55. And if there's a sodium voltage gated channel there, what's going to happen? It's going to open, you get an action potential in the neighboring cell. Not because it was stimulated, but because it was electrically connected together with its neighbor through a gap junction. And when you have a bunch of parts working together, that's called a syncytium. And so the gap junctions that we have create a functional syncytium in which when one cardiac muscle cell gets an action potential, all of the muscle cells, because of all the gap junctions that are connected one to another, they all get the action potential. So they're all going to contract at the same time.